So this is a paper looking at Teprotumumab, which is sort of the next best thing for big thing in thyroid eye disease. And this is the most recent paper that was published last April. And it was a pooled analysis of the two phase 3 RCTs. And they also had some subgroup analyses that they did and sort of longer term follow-up from both trials. So I'm just going to run through a little bit about thyroid eye disease and sort of current treatment options, given the UGOGO guidelines were updated last summer. And then sort of what the results showed and some work that will be going on within Imperial as well with Tepro. A little bit of background about thyroid eye disease. So main things is it's characterized by inflammation. So there's edema, redness and swelling, and there's expansion of fat, connective tissue and muscle within the orbit, which then gives rise to some of the clinical features, clinical symptoms of proptosis, strabismus, and diplopia. And the two sort of, there's lots of things going on from an immune response, but the thyrotropin receptor and the IGF-1 receptor are sort of the two major autoantigens and sort of a crucial trigger point, which leads to the downstream kind of immune cascade that leads to the above sort of inflammatory response. So with the thyrotropin receptor and the IGF-1 receptor, they form a sort of a complex within orbital fibroblasts. And then it's the signaling through this complex that leads to downstream effects and accumulation of hydrophilic glycosaminoglycans, and then this sort of resultant expansion of orbital fat and muscle. So I'm sorry, this is kind of a bit blurry, but this gives you an idea. This is the fibroblast, and then you've got the thyrotropin receptor and the IGF-1 receptor, and then sort of stimulation of this complex then leads to downstream effects. So you have inflammatory cytokines, and then differentiation of the fibroblast into myofibroblasts and adipocytes that then lead to muscle and fat deposition, and then increased sort of connective tissue with hyaluronic acid and other glucosaminoglycans that are produced. So just kind of worth having that in mind, because I'll go through how Tepro acts in a moment. Obviously, thyroid eye disease has a very big impact on patients, particularly with daily activities and a psychosocial effect, certainly with visual impairment and facial disfigurement, the latter being a real issue. We use a number of different scoring systems, but some people are probably familiar with the Graves Orbitopathy Clinical Activity Score. We often look at 1 to 6, but 1 to 10 kind of the later separate parts look at the impact on patients. So the first couple of sections look at symptoms that patients have, so pain and redness, and then sort of signs such as swelling, so looking at swelling of the eyelids, carbuncle, and then effects seen clinically in terms of proptosis, and then the effect on function in terms of eye movements and visual activity. So this is done when patients are seen in the MDT, we clinically score them. And the other thing we do is a quality of life questionnaire, the Graves Orbitopathy questionnaire, and this is divided into two parts. So the first part asks about patients in the last week, the number of things they've experienced, and it's the impact in terms of their daily activities. As you can see here, so things like driving, walking around, reading. And the second part of the questionnaire looks at how they feel their appearance has changed due to their thyroid eye disease. And then they have a total score at the end of this. And this is one of the things, this and the CAS score were looked at within the trials. So current treatment options are actually quite limited. High dose glucocorticoid therapy is sort of mainstay, and now MMF therapy as well. And then at second line, other immunosuppressive therapies such as Rituximab. And there's also retrobulbar irradiation. And then in those who don't respond, use of surgery to try and improve some of the clinical features that are really disabling for patients. So these are taken from the UGOGO guidelines that were updated last summer, and just sort of the first line treatment for moderate to severe disease. So you have general recommendations, so the need for patients to be seen in a thyroid MDT, to stop smoking, to make sure that they're clinically euthyroid as best treatment, and then to avoid iatrogenic hypothyroidism as well. And so mainstay of treatment is really IV glucocorticoids, so methylprednisolone, and then adding in mycophenolate or MMF. And certainly in Imperial, we give a 12-week course, so we would do 500 milligrams of methylpred the first 6 weeks, and then we would reduce that to 250, and then we've actually started in the last couple of months giving MMF, but we do a 24-week course of that, and then we assess. There are trust guidelines that are in process of being finalised. I'm not going to touch on those today, just because there's some additional things that need to be finalised before we can brief everyone. And certainly at second line treatments, it's whether you then give further IV methylpred, and this isn't without side effects. There are a lot of side effects to giving high dose steroids, especially glycemic control. And then it's continuing steroids orally with something like cyclosporin or azathioprine. There's use of radiotherapy again with glucocorticoid cover. There's rituximab and tocilizumab as other immune suppressants, and then Teprotumumab, which was licensed by the FDA in 2020, and so has come out to be sort of the next big thing in terms of hopefully improving outcomes for patients with Graves' orthopathy. So Teprotumumab, or Tepeza, which is its brand name, is an inhibiting monoclonal antibody receptor against insulin-like growth factor 1 receptor. So I move on to the next slide. I talked about this sort of complex earlier, and this is where the signaling really occurs. So Tepro blocks part of the IGF-1 receptor in its extrinsic part, and then that stops the formation of this complex that then attenuates the kind of the downstream effect in terms of producing or differentiating fibroblasts into adipocytes, myofibroblasts, and the production of hyaluronic acid, which then reduces the soft tissue expansion and will also stop some of the downstream cytokines that are produced. In terms of other treatments, rituximab blocks CD20, producing B cells, which has an effect on the inflammatory response. Tocilizumab blocks one of the activating cytokines, IL-6. So I hope that sort of makes sense and gives a bit of background as to how Teprotumumab is felt to work.
Yeah, it does. The other ones aren't licensed, are the rituximab and tocilizumab, and have they been tried? I think we tried once or twice, but it wasn't very effective.
No, I mean, I'll talk about it in the discussion, but the rituximab there have been a couple of trials, but very limited improvement. I think we have given patients clinically, but I don't know what their responses are. I don't know whether Vicky Lee's on the call. She said she might try and join, but she's got some experience.
Yeah, she has. I saw Ahmed's on.
Yes. Can you hear me?
Yeah. Have you had any experience of using rituximab or the other ones? Tocilizumab?
We have used the rituximab, but only in I think one case, and it was effective, NICU, but we tend to use it only in people who have not been receptive to steroids, and then mycophenolate, and then orbital decompression and site-threatening disease, and that requires special funding.
Yeah.
Okay, thank you.
So this is sort of a take-home picture, which was done in a sort of a visual abstract in one of the papers that was pulled. So it's just looking at the clinical photographs of an example patient. So baseline in the placebo group, you can see there's not very much change after 24 weeks of treatment compared to the Tepro group, where there was a real improvement in clinical features. And again, in the MRI findings, a reduction in sort of orbital fat deposition as well. So that's a bit of background about Teprotumumab and what's been seen. And then this study was looking to combine the two RCTs, which were pivotal, and they really wanted to focus on two responses, which were Proptosis and Diplopia, which is very hard to treat. And they, by pooling both groups, they were able to look at different patient subgroups, and they had some follow-up analyses that were looked at off treatment. So at 7 weeks after treatment, that was at week 28, and then at 51 weeks following the last infusion treatment, which was at week 78. So the design, they pooled two randomized trials, both were double-blinded and placebo-controlled. They were both multi-center, so they spread over 28 academic tertiary centers across both the US and Europe. Participants they're all adult patients with a diagnosis of Graves' disease, and in the first study they were aged between 18 and 75, and in the second study between 18 and 80. They all had a recent onset of active thyroid eye disease, so less than 9 months duration, and it was all, say, with an active score, so their CAS score had to be greater than 4. And they are excluded if they had previous medical or surgical treatments. They were allowed if they had had a previous infusion of IVMP, but they had to have a 6-week washout period prior to starting the Teprotumumab. So in terms of procedures, both studies had 8 infusions of Teprotumumab or placebo, and that was carried out every 8 weeks. Their first infusion was 10 mg per kg, and then the second infusions and the infusions from then on were 20 mg per kg. And then they had a final study visit at week 24, which was 3 weeks after the final infusion at week 21. So this is sort of the pool. I'm sorry, it's probably a bit blurry on the screen. This was sort of an overview of the trial profile. So the first study was performed by Smith et al. And seconded by Douglas et al. And basically the thing you want to look at is how they pooled them. So in the first study, they randomized 88, and the second, they randomized 83, with 45 placebo in the first and 43 treatment Teprotumumab in the first trial. And then in the second trial, 42 had placebo and 41 Teprotumumab. So combined, that gave 87 who were given placebo and 84 Teprotumumab. In both groups, there were 8 who discontinued due to adverse events and withdrawal, which we'll go through a bit later. So there were 79 who completed the treatment with placebo, and there were 76 who completed who were given Teprotumumab in the 24-week period in terms of the pooled data. So in terms of their outcomes, they used an intention to treat analysis, and they took all that data up to week 24. Their primary outcome, so the 2 studies had slightly different outcomes, but both included proptosis response with a greater than 2 millimeter reduction in the study eye, no deterioration in the other eye. So that's sort of what they included. I think study 1 had CAS as well in that main outcome, but for the purpose of the pooled study here, it was proptosis response. And they also stratified the response by tobacco non-use and current use. And they had a number of secondary endpoints. So they looked at diplopia response and the proportion of patients who improved. They looked at the overall response, which was a reduction in proptosis and a reduction in CAS. They looked at the proportion of patients with disease inactivation. They also looked at the mean change from baseline proptosis and the mean change in their quality of life scores. And they said that a positive point change of 10 and 20 was considered a moderate or large response. As with any trial, with safety assessments, so they looked at adverse events, they looked at vital signs, general laboratory blood tests, and Tepro immunogenicity as well, so antibodies to Teprotumumab. There are a few other pre-specified assessments they looked at. So they wanted to look at the proportion of patients with significant abnormal findings, such as changes in acuity, deteriorating colour vision, intraocular pressure, and slit lamp exam. And then within each
here, is it? Checking it? Over there, correct.
They wanted to look at different subgroups. So the subgroups they looked at were tobacco use, either current or not, no current use now. Age, so less than 65 or greater than 65, male or female, time to diagnosis of their Graves' disease or their thyroid eye disease, their CAS score, and then baseline TSH receptor antibody concentration. And then obviously their additional outcomes, they looked at so they looked at week 24, what the main their main outcome, and then they looked again at 7 weeks following this, so at week 28, and at 51 weeks, so week 72. And they had a number of post hoc assessments for disease severity, so looking at constant proptosis or greater than 3 millimeter proptosis, constant diplopia, and then they talk about an ophthalmic composite outcome, which was an improvement of sort of proptosis in more than one eye from baseline without deterioration in the other. So I looked at proptosis, CAS score, absence of eyelid swelling, and lid aperture changes. And so they looked at the longer term responses at week 28 and 78, and that was assessment of proptosis and diplopia and thalamic composite scores. And where possible, they tried to pool all the assessments. They weren't, so if they weren't reported for that study, they obviously weren't pooled. If there was missing data, they assessed data at individual patient data at the last visit point. And they defined non-responders as those who needed medical or surgical treatment within the study period. There were lots of complex statistical analyses that they did, but mainly the primary analysis was weighted by each of the strata they looked at. And obviously it was stratified by study 1 and 2, and then whether they were tobacco non-users or users. And then they used a mixed model analysis for repeated measures over time, so things like proptosis and CAS scores that were repeatedly done over the 24-week period. They calculated a number needed to treat for all the major outcomes. They had some additional sensitivity analyses, and then there was a post hoc analysis as well. They wanted to look at the correlation between proptosis and appearance scoring on the sort of questionnaire. And then also look at overall risk differences between both placebo and Tepro for adverse events. So there's a number of things they looked at. I'll just sort of go over the main headline things. So in terms of general results, both studies ran over a couple of 1 to 2 year periods. So study 1 between 2013 and 2015, and study 2 between 2017 and 2018. In terms of the pooled ITT population, as I showed on the combined diagram, there were 84 Tepro patients and 87 placebo patients. And the completion rate in both groups was nearly 91%. So 76 out of 84 who were in the Tepro group completed the trial, and 79 out of 87 of the placebo patients completed. This is just sort of a broken up slide, but I couldn't put it all on one long slide in terms of the kind of baseline characteristics, but there's not really much to note. They're all pretty comparable, certainly in terms of age. There were more females in the compared to males in both treatment and placebo groups. In terms of smoking history, there were more non-smokers than non-smokers within both groups. And then in terms of baseline medications, they were pretty similar. There were slightly more who were taking carbimazole, for example, in the placebo group. In terms of their actual other autoimmune diseases, slightly more in the Tepro group, but they didn't show any significance. And then they looked at baseline CAS scores. So actually there was, these are pretty similar between the two groups. Again, patients with diplopia, so slightly more in the Tepro group, particularly those with constant diplopia. And then in terms of their overall scores in their quality of life questionnaire, again, very similar between the groups. And then in terms of their free thyroid sort of hormone levels, so free T3 and free T4, again, they're pretty similar between each group. In terms of the TSH receptor antibodies, it got a bit complicated because the two studies looked at them slightly differently. So in the first study, study 1, they looked at a percentage inhibition, whereas study 2 actually looked at an amount. So when they looked at the subgroup subsequently in TSH receptor antibody, they just look at study 2. Does anyone have any questions so far?
Apart from that, the two studies were identical, were they? The second and the first?
Pretty much. I mean, there's slightly different sort of main outcomes they were looking at, but in terms of how the study ran, study 2 had more follow-up period time, so they've counted that later on in the results. So there were study points in the follow-up that study 2 had that study 1 didn't, and study 2 also had an open label section. So after 24 weeks, if there was deterioration, they went on to open label Tepro.
Right.
They haven't really talked about that here.
Okay.
The main thing was up to 24 weeks, where the study was study design was very similar.
Thank you.
So in terms of the take-home results, so basically patients did much better on Teprotumumab. So in terms of a reduction in their proptosis of at least 2 millimeters, 77% of the patients achieved this with Tepro compared to 15% in placebo. There was a stratified treatment difference of 63%, and that was significant. And again, a greater change from baseline in terms of proptosis compared to baseline to week 24. So a difference of minus 3.14 millimeters compared to minus 0.37 in the placebo group. And again, this was significant. In terms of the numbers needed to treat to give a response in proptosis, 1.6, diplopia 2.5, and overall response 1.7, and disease inactivation 2.5. They went on to do a fairly complex sensitivity analyses, but take-home message from this is that basically there was increased proptosis response with Teprotumumab compared with placebo, and that was looking at different types of sensitivity analyses. They don't specify in the paper what a per protocol and modified ITT are, so I'm afraid I can't give much more detail, but the point being just that there was a greater difference in terms of the number of patients who responded with Tepro compared to placebo, and then just the difference between the two and the fact that they were all significant. They say they looked at different subgroups, and they felt that, well, they found that with an integrated response between both trials, there was a better response in Teprotumumab compared to placebo across all the subgroups. And those who had the greatest baseline proptosis actually had the biggest reduction. So I'm sorry, this probably looks a bit blurred, but this was how they presented the results for the Teprotumumab and placebo for proptosis, and I've got one for diplopia coming up. So basically 0 to 100 favors the Teprotumumab. So this is the treatment difference between placebo and Teprotumumab, and then if it's going the other way, it favors placebo. And in particular, patients who were tobacco users, the difference was sort of 47%. And the other one to note would be those who were older than 65 had a greater response as well, compared to those who were less than 75 years. So yes, Teprotumumab had a greater effect in patients taking, in proptosis response. And then in terms of diplopia response rate, so again, Tepro showed a higher response rate at all visits, so 70% in the Tepro group compared to 31% in the placebo group. In terms of full resolution of diplopia at 24 weeks, there was 53% of the Tepro group compared to 25% of placebo, an improvement in constant diplopia of 71% compared to 18% at the end of the 24-week period. And then across subgroups, so there was a greater response in diplopia with the Tepro, except in those who used tobacco and in those with a TSH receptor antibody level of less than 10. Of note, both had a low numbers needed to treat for response. So in this, again, it's a similar sort of graph. So on the right, favouring Teprotumumab use, and on the left, favouring placebo use. So in those who used tobacco, the confidence interval is -3 to 62% difference, and then baseline thyrotropin receptor antibody levels less than 10, again -3 to 65. In terms of the overall response, so they looked at the CAS score plus improvement in proptosis. So in terms of having a CAS score of 0, 1 and sort of CAS alone, that improved significantly with Tepro compared to placebo, and that was seen at each time point. And then the overall response was again improved with Teprotumumab at week 24, and the treatment difference between placebo and Tepro was 60%, with the numbers needed to treat of 1.7. In terms of the quality of life, so again, greater improvement with Tepro compared to placebo at 24 weeks. So the score increased by least squares mean of 19, and there was a baseline of 6. So their baseline scores were very similar, but the increase an improved score of 19 compared to 6.3 with the placebo group. They've talked about a very small non-significant correlation between changes in appearance related score and proptosis reduction. So i.e. if your proptosis reduces, does that increase your score in your GeoPol questionnaire? They've said there's a very small, but it was non-significant. And actually there was no correlation between this score and those with constant diplopia. They went on to look at thyrotropin receptor antibody response subgroups. So this was just in study 2, because study 1 showed them as a percentage as opposed to an actual value. So they divided up into a level of greater than 10 and later level of less than 10. And basically both subgroups showed a mean reduction of at least 3 millimeters of the Teprotumumab. So this is just looking at the numbers who responded in terms of proptosis score in the Teprotumumab group compared to placebo, and then just the difference between the two. So change in proptosis from baseline was significant, and again an improved response in diplopia as well. And that was seen in, say, this is a group with a higher TSH receptor antibody level, and this is seen in the group with a lower level. So there were robust responses throughout both groups. They went on to look at follow-up data. So at week 28, which was 7 weeks after they had their last infusion, there was no evidence for acute rebound disease. And in terms of their main responses, these were maintained. So there were still 87% of patients responding with an improvement in proptosis, 60% in diplopia, and in terms of their composite outcomes, 92%. So that's seen here. So at week 28, again in proptosis, 80%, there are 87% of responders, in diplopia 66%, and then the composite outcome 92%. And then at week 72, so that's 51 weeks after the last infusion, 67% still had a response in proptosis, 69% in diplopia, actually slightly more than at week 28, and then composite outcomes, so 83% had a response. The light blue are just for the second study that had more follow-up visit events after the infusion stopped, where they obviously couldn't pull the data. And then here shows the mean change from baseline in their transform scores for their GoQol results. So they're pretty consistent results throughout the follow-up period. And they've just subdivided it into the appearance subscale, and then the overall, and then the visual function subscale as well. So then obviously at 51 weeks after the last dose, as I mentioned, there were good responses in the Tepro group with proptosis of 67%, diplopia 69%, and composite outcomes 83%. Of note, in the placebo group, 11 patients had 20 treatments for their thyroid eye disease during the integrated treatment and follow-up period, which included 10 decompression surgeries in 6 patients. In the Tepro group, in comparison, 8 patients had 14 treatments, and that was for decompression surgeries in the follow-up period. So this is in study 2, 13% of patients on Tepro were non-responders, so they required further treatment, and 23% of patients flared during their follow-up period and were retreated with Tepro. In terms of their adverse events, so there were 7 adverse events, or severe adverse events, in the Tepro group compared to 3 in the placebo group. And these included IBD, flare, and what else there was? Hypoglycemia occurred in 8 patients, and there was a couple of patients who were diagnosed with diabetes, and there was significant diarrhea in about 12% of patients. Of note, those who didn't continue, one of the adverse events was encephalopathy, Hashimoto's encephalopathy, and confusion, and they certainly withdrew. and then diarrhea. And I know that, just bear with me a moment, in terms of the severe adverse events and the follow-up period, one was for intercostal neuralgia, and the other was for optic neuropathy. There were no severe adverse events in the follow-up period in the placebo group. Of note, hearing impairment is about 10%, and it's certainly been something that's been flagged with teprotumumab. The authors say that there was no sort of ongoing loss, and that actually things didn't get worse in the follow-up period. And actually, I think in a couple of patients it improved. So they don't sort of harp on about hearing impairment. I know it's been a concern in people sort of using teprotumumab more. So sort of main discussion points. This was a large study population, actually one of the largest study populations with thyroid eye disease. It included both short-term and long-term sort of efficacy and safety in terms of follow-up, and had patients with different disease severities. And it was they looked clinically relevant outcomes, improvements in GO-QOL scores, including looking at their visual sort of changes and appearance impact. They showed a very, I'm not sure I'd call it even small, it's very small, non-significant correlation between improvement in proptosis and appearance. They say this could be due to effective baseline levels changing over time, and possibly an effect of whether you're male or female, and they've identified this as something that need to be looked at further. In terms of strengths, I've mentioned it was one of the largest controlled study populations of thyroid eye disease, and they looked at a number of different subgroups who'd be at risk for more severe and difficult to treat disease, such as those who are currently smoking. They looked at questions around disease rebound and longer term responses, and they didn't identify really any new adverse events during the follow-up period. So the adverse events were not felt to be due to the teprotumumab, they were separate. They made the point that actually there's a lot of morbidity associated with glucocorticoid use, and also with rituximab, it's been a case of compressive optic neuropathy. So alternative therapies are not without side effects either. They go on in their discussion to sort of talk about other different immunosuppressive therapies and how they feel Tepro would compare. So in terms of using glucocorticoid therapies and MMF, so in terms of the main ophthalmic composite outcomes, in this study, 90% met the outcome, compared to with 53% with IVMP and 71% with IVMP and MMF combined. There were improved disease and activation rates and GO-QOL improvements with Tepro. There have been other trials which were non-placebo and unmasked with glucocorticoids, and they gave larger improvements, but again, it's non-placebo and unmasked trials, so it's difficult to try and draw a comparison. They also, the studies looking at glucocorticoids, they had younger patients with a longer duration of TED, so again, difficult to compare the two groups.
When you say larger improvements, you mean with the steroid?
Yes.
Yeah.
Yes. So they talk about, I'm afraid I haven't read the papers, but there were the other papers looking at high dose glucocorticoid therapy claimed, or showed large improvements. But again, this was, sort of inferior study because it was not placebo controlled and it was not blinded. So then looking at other immunosuppressive therapy, so tocilizumab, which is an anti-IL-6 monoclonal antibody. So that's shown improvement in 73% of patients compared to 29% placebo. We said 90% in our Tepro group from before, but the moderate decrease in proptosis from baseline wasn't sustained at 40 weeks, and there was only a minimal improvement in Diplopia score. So again, not quite, so the results weren't as strong as Tepro. And rituximab, there have been a couple of RCTs, so comparing either with placebo or with IVMP, and in terms of looking at disease and activation in patients at 24 weeks, and reduction in proptosis. So basically, no patients had a reduction of greater than 2 millimeters in proptosis. The improvement in diplopia was seen in rituximab was similar to that with glucocorticoids, and again, just no real benefit over placebo. in terms of composite outcome. So in terms of this study and its limits, so obviously they combined 2 different studies, and both studies had slightly different follow-up visit timelines. So study 1 didn't have the follow-up visits, sort of study 2 did. It just had it 28 weeks and at 72 weeks. Study 2 had more visits, but it was open label with any flares. So it limits the pooling of the data in terms of follow-up. They only looked at patients with CAS scores of greater than 4, so active disease. Were unclear about the effects in chronic thyroid eye disease. And they also only looked at patients who had they'd only been diagnosed for 9 months or less. So a lot of the patients we see have had a longer duration of Graves' disease diagnosis. And they've also said there's basically a need for larger, more diverse patient populations, but given the prevalence of thyroid eye disease, it's actually pretty rare to cohort of patients. So actually this was a really large study, and so the best we've had so far, but again there's need for increased diversity in terms of their clinical features. So in conclusions of take-home messages, so study looking at pool data from 2 big RCTs showed a significant and clinically meaningful improvement using Teprotumumab. Results were pretty consistent and had some long-term benefit, but we really need long-term, so further follow-up studies